All right. Hi, everyone. My name is Sayeh. I'm a fourth-year medical student at Penn State Hershey right now. I'm applying into interventional radiology right now, and wanted to give this webinar on futility in interventional radiology through the Trainee Applied Ethics and Palliative Care Committee. We're going to do some poll everywhere, like discussion questions later. So my login information is at the bottom of the slide. So if you could just log into that, you can do it preemptively or once we get right to the questions, and then we'll go from there. Thanks for coming. I have no disclosures. And I first wanted to just say thank you to two of my mentors in helping me make this webinar and kind of making this all happen. Michelle Schneider-Adams, she's an integrated resident at the University of Michigan, and she really helped me come up with like the content of this webinar and really helped out with the editing process. And then Eric Keller is an integrated resident at Stanford, and he is the creator of the Applied Ethics and Palliative Care Committee. So without him, none of this would be possible. And he's been a great mentor to me the last couple of years, helping me discover my passion for ethics and IR. So just to jump right in, so what does futility mean? This was a term that was first introduced in the 1980s, and it was introduced as a of terminally ill patients. And generally, futility is considered a pretty complex subject, and it's difficult to define, but Schneiderman's definition is currently the most commonly accepted definition. And his definition is the unacceptable likelihood of achieving an effect that the patient has the capacity to appreciate as a benefit. So basically, he's saying that, you know, there is an action that can be taken to achieve a certain effect or a goal, but it's clear that that action will probably fail to achieve that goal. So things to consider when we're talking about medical futility: the goal of treatment, is the goal therapeutic, palliative, curative? You know, that's something important to consider. You want to determine the physiologic effect of the treatment you're performing. You want to consider the utility of the treatment and also the value of the treatment. So that kind of brings in the concept of the harm-benefit ratio, considering how much this treatment will help the patient versus hurt the patient. And then lastly, something to think about is who even has the right to determine futility. And this kind of brings into question, is it the patient's right, the family's right? Is it just up to the physician? So also important things to consider. Before we really dive into talking about this, I just wanted to bring up the concept of the changing terminology over time. So a futile procedure is defined as an intervention that definitely cannot accomplish an intended physiological goal. So for example, it would be like performing CPR in a patient with a ruptured myocardium. You know, this is something that's definitely not going to help the patient live. They are not going to survive, and that treatment ultimately will be futile. So this term should be used pretty rarely because these can be pretty exceptional circumstances. Some terminology that's become more, I think, appropriate to apply to these scenarios is calling procedures potentially inappropriate. And that's defined as an intervention that has at least some chance of accomplishing the effect that is sought by the patient. So in this case, while the procedure has a chance of achieving the patient's desired goal or effect, physicians in this scenario may believe that there are competing ethical interests or considerations that justify not providing that treatment. So just for the sake of this discussion, I'm going to be using the term futile, but again, I just want to emphasize that it's important to remember that defining this terminology is really difficult. But ultimately, the goal of this webinar today is just to kind of create a framework for starting to think about these topics and trying to bring to mind things you should consider when providing care and these kinds of situations arise. So why should we even care about futile care? With the rising elderly population and advances in medical technology, the possibility of providing futile care is becoming much more common. And with that will require more ICU personnel and more resources that are needed to prolong the lives of individuals with these chronic illnesses who most likely might not survive anyways. Additionally, in this new technological age, there's an increased opportunity for misinformation among patients. There's more information available on the internet and more opportunities for patients to do research on their own time. So there's more chance of them getting the wrong information or just being misinformed. So as a physician, it's really important that you play your role in providing them with all the correct information so that they can make the most informed decision. But again, because individuals have these opportunities to do their own research, this may create outside pressures from family, friends, loved ones, which again may put pressure on you as a physician to provide care that you may not think is medically or ethically justified. By providing futile care to patients, it may create the potential for providing worse care to other patients. For example, with more patients staying in the ICU, that can create bed shortages and shortages of resources, which could be used to provide care to other patients who may need or benefit from that treatment more. Another point to consider is it impacts the quality of life of both the patient and their family. It impacts their psychosocial well-being. It can create a financial burden on them. And the family may not be prepared to handle this and may not be aware that it could be a potential consequence of this treatment. And lastly, providing futile care can have an impact on healthcare providers by contributing to moral distress and burnout. So moral distress is defined as when someone knows the right thing to do, but there are institutional constraints that make it pretty much impossible to pursue the right course of action. So this can lead to feelings of anger, guilt, anxiety, helplessness, powerlessness, and these feelings can build up in a healthcare provider and ultimately impact their well-being, which, if you go down the line, that will impact patient care eventually. And additionally, if physicians are fearing legal ramifications or feel conflicted between their morals and between what their patients and their patients' families are asking of them, this really creates a burden on these healthcare providers. So the learning objectives today is to define futile care and understand the different types of futility. We're going to try to gain a deeper understanding of what futile care really means in the context of IR, and this is when we'll dive into some case examples. And lastly, we'll talk about some strategies for mitigating continued provision of futile care. And again, I just want to emphasize this is not the end-all be-all definition of futile care, but I'm hoping that at least beginning to have this kind of discussion and providing this framework will help people when they encounter these situations at least have some way to approach it. So there are different types of futility, and they can be defined in different realms. So one common definition is between qualitative and quantitative futility. So qualitative futility can be defined as how feasible it is to achieve the patient's or family's goals, versus quantitative futility, which is a little more concrete, which is defined as how successful has a treatment been in 100 other similar cases. On the other hand, there's also value versus goal futility. Value futility means that the intervention can obtain an effect, but it's not necessarily a benefit. And this is compared to goal futility, which is defined as an intervention that will ultimately not alter the course of events. So if you have a certain end goal in mind, then what kind of procedures considered futile may change depending on that goal. And something I wanted to bring up that I thought was important was addressing if admitting futility also admits to hopelessness, because oftentimes I think these terms are associated with each other, and obviously admitting hopelessness has a very negative connotation. So I think it's really important to differentiate these concepts for patients and their families, and helping them understand the difference between futility and hopelessness. So saying the procedure is futile, I think it's important to emphasize to patients and their families that this is an objective possibility or probability of something happening. It means you're saying that there is a really low chance of a procedure, intervention, or treatment really benefiting the patient. And it's really important to demonstrate that this is not your opinion, but it's based on previously established evidence. And this is compared to hopelessness, which is more of a subjective attitude based on emotion. And admitting something is futile does not necessarily mean you're admitting that it's hopeless. I think the concept of hope is something that is maintained by the patient and the family and even the physician in discussing future options. So, for example, a patient choosing to pursue palliative care can still maintain a hopeful outlook on their future. For example, they can maintain hope that they will live the rest of their life with more controlled pain, and they'll be able to have some joy in the time that they have left rather than spending that time in a hospital and continuing their suffering. So I think this is also an important concept to think about as a physician, although it does add on to, you know, the many roles that physicians have. But if there's any way you can show patients that there is a way to maintain hope even in a situation that seems hopeless, that's a really important impact you could also have on their care. Another important distinction is differentiating futile care between palliative care and resource rationing. So palliative care is defined as care that's focused on providing relief from the symptoms and stress of an illness that cannot otherwise be cured. So new goals of care, like I previously mentioned, they can include controlling patients' pain or providing care to improve other needs of the patient, which could be psychological, spiritual, or social needs, and prioritizing those over their medical needs. So again, this implies that the goals of care have changed. So essentially anything done in palliation cannot be considered futile because this care is fulfilling new goals. And this is different from resource rationing, which is defined as an allocation of resources due to a shortage. So when you're talking about resource rationing, it implies that a treatment would actually benefit the patient, but the availability of resources is the limiting factor. But this is really different from futility because futility is implying that the treatment and the resources are available. However, the intervention really wouldn't benefit the patient. So ultimately, it's really important to understand the goals of care, which have hopefully been established with the patient through previous conversations with them and their family. And that will be the best path to providing the best care moving forward. So some ethical principles to consider when talking about providing futile care. You know, we all take the Hippocratic Oath when you become a physician to do no harm. And I think it's important to acknowledge that performing futile cares can ultimately hurt patients instead of helping them. So it's just something to consider. I'm pretty sure in medical school, we all learned about the 4 basic principles of healthcare. So I won't harp on these for too long, but you know, they're listed here: respect for autonomy, beneficence, non-maleficence, and justice. These, again, are all things to consider when respecting your patient's wishes and goals of care, but also understanding that you know what will ultimately help or hurt them medically. And lastly, an important concept to consider is physician paternalism versus patient autonomy, and this kind of plays into figuring out who has the right to determine what a futile procedure is. So physician paternalism is defined. It's a concept that the physician knows what's best for the patient and unilaterally makes decisions regarding patient's care. And I think there's been a shift in healthcare where previously this was a concept that people really heeded to, but now it's much more of a conversation when providing patients care, and they have a much more active role in determining their care. So now we'll jump into some case discussions. So if everyone could log on to the poll everywhere, and we will dive right in. So the first question is, we have a patient with terminal cancer. They're found to have a GI bleed, and the primary team consults IR about performing an embolization. So what is the best course of action? You can perform the embolization, you can refuse to perform it due to poor chance of survival, ask the primary team about the patient's goals of care and go from there, or ask the patient if that's what they want to do and go from there. Or if you have another idea, you can select E. So I believe this should be active. So I'll wait a couple of seconds for everyone to put in their answers. Okie dokie, I will show the answers. So, oh. Okay, there we go. So it looks like most people said they would ask the primary team about the patient's goals of care and then proceed from there. And some people also would say that they would ask the patient about the embolization. And I think both of these are good answers. You know, it's important to have an open and honest discussion with everyone involved in the patient's care. So it'll be important to talk with the primary team to kind of get a better understanding of the situation. And it'll be important to talk with the patient as well to kind of see where their head's at with their ultimate goals and what they're looking to get out of that treatment.
Sayeh, I don't know if you can show us the poll results. I don't think that we were seeing them just now.
Oh no, they're coming up on my screen. Oh, shoot. Is it coming up now?
No, we still just see kind of the slide that just shows option E with 100%.
It just reloaded for me. How about now?
No, maybe it's on a different monitor, but it's okay. If we can't see it, you can just share the results verbally.
Yeah, I can, sorry about that. I thought I figured out the poll everywhere sharing. But I can tell you the percentages. So we have 67% of respondents said they would ask the primary team, and then 33% said they would ask the patient. But again, I think those are both solid answers, and both are important ways to approach this kind of situation. So some points to consider: encourage early and frequent conversations with patients and their families in order to establish goals of care so that everyone's on the same page. And then this will ultimately ensure that the patient receives optimal care, because if everyone knows what's going on and everyone has the same end goal, then there will hopefully be fewer misunderstandings. And again, it's important when having those discussions about goals of treatment to differentiate between a palliative and a futile procedure, because the goals of the treatment will make that determination. So for example, if the patient's goal was to avoid or delay death, then performing the embolization would not be considered futile, because surely taking care of that bleed would prolong their life. But if the patient's goal was survival, then this procedure would be considered futile because, you know, they have terminal cancer, so this will not cure them. Okay, so our next question.
Before we move on, I just wanted to add that I think if you go back to the potential responses, I think everything that is listed, chatting with the patient and then talking to the team, like you had said, like those are all great things to consider, and that there's not really a right answer here, that it's a multifactorial decision that requires a lot of different inputs from different parties. And so, like you've already mentioned, that you have to kind of come up with a plan together as a team, as opposed to kind of unilaterally and making a decision and kind of going with a paternal approach. So just wanted to add that.
Yeah, thank you. I think, and it's really helpful to get a resident's perspective too, because, you know, you're more in it. So thank you. And then moving on to our next question, or our next case. So we still have that patient with the GI bleed. So you actually decide to perform the embolization because the family has continued to pressure you and even made threats of taking legal action against you if you do not perform it. So what do? You could perform the procedure to avoid any legal consequences. You could try and talk to the family first and figure out why they're so insistent on having the procedure done. You could also consult with the hospital's ethical and legal teams and see if they would participate in a family meeting with you to facilitate that conversation. So I think you guys should be able to throw in some answers. Maybe this time it'll actually show them. Wait a couple more seconds. I think almost everyone has answered. Okay, perfect. I'll show the responses, so hopefully it shows up on your guys' screen. So I don't know if you guys can see it, but 25% of you said you would try to understand why the family is so insistent on the procedure and go from there. And then let's see. Oh, actually it jumped to 33%. And then 67% of you said B and C, so that you would talk to the hospital's ethical and legal teams and see if they would participate in a family meeting with you. So again, kind of similar to the last question and to Michelle's point, I think both of these are really good options. It's important to understand where the family is coming from and try and figure out what their motivations are for performing the procedure, trying to understand their background and seeing, what they understand is really important before moving forward. And getting help from others, I think as a physician is really important, and especially if it's a conversation or a topic that's maybe outside of your comfort zone or you haven't dealt with before, it's important to get help if you need it. So again, some points to consider. As I mentioned previously, providing futile care contributes to physician burnout and moral distress. So, maybe the first answer of providing the embolization and just doing the procedure to avoid the legal consequences, that may have been the easier option. But ultimately, I think providing a service that you feel is futile, those kinds of scenarios will build up and ultimately contribute to feelings of burnout and moral distress. And these can have a really negative impact, I think, personally, professionally, and mentally. So it's important to try and avoid creating that moral distress when you can. Another point to consider, like we already talked about a little bit, there can be many reasons why a family and a patient are so persistent about getting a procedure done. It may be a religious, a spiritual belief, a cultural belief, it could be anything. So it's really important to try and assess and understand the reason for their persistence and try to address that when you talk to them about why you feel that the procedure isn't necessarily warranted. It's also important to explain the expected harms versus benefits that the patient will experience from the treatment. Because again, maybe putting it in these terms will help the patient and their family better understand kind of where you're coming from and better understand the consequences of moving forward with the procedure. Something else to consider is that it's important for you to explain to the family that you can still offer the patient some benefit by providing palliative or end-of-life care. There can oftentimes be a misconception that providing this type of care is just a physician giving up on a patient, but it's important to show that that's definitely not the case. It's just your way of figuring out how you can best help the patient in the situation that they're in. And lastly, going to that answer that talks about the hospital ethics and legal teams, use hospital resources that are available to you. You can reach out to these teams at your institution if they're available, and they may be able to provide you with help, guidance, advice, or even participate in that conversation with the patient and their family, so that you can show the patient that you care about, you understand where they're coming from and you care about providing them the best care possible. So yeah, I think these are all important points to consider. And then
just to add Other
Oh yeah.
thing. No, I think all of your points are very, very well made. Just one thing, kind of just like you were saying from a resident's perspective, it's difficult to do these things. Like it's really time consuming to go and chat with the patient for a long period of time, call the family, especially if the patient is not mentally fully there. And so it requires a lot more time and effort to communicate with all the relevant parties, and then sometimes like even finding what the hospital resources are is like very cumbersome. So I don't want to discredit the fact that doing kind of the ethically correct thing is always easy, but I think that we still as professionals have an obligation to work towards making the ethical choices in our jobs on a day-to-day basis. And so the more that we can keep these things in mind, I think the easier it'll become. Because like the first time, let's say if you're looking for what hospital resources are available, you can kind of search your hospital system and online, or chat with somebody about it, and then eventually you'll know. So then it'll take even less time. So I just think it's important for us to get this on people's radars so that we can kind of make the right decisions more frequently.
Yeah, definitely. Thanks so much, Michelle. And I mean, I can say even throughout my rotations, I've had a few experiences when we've had to talk to legal teams, and it definitely seemed like it can be hard to get in touch with these teams and even know what resources are available to you. So I definitely understand that this can be a difficult process, but hopefully we can figure out ways to make these kind of team meetings more easier to do, I guess. And then the last case we will discuss. So in this scenario, you actually decide not to perform the embolization on the patient with the GI bleed. And now you must talk to the referring team and the patient and their family. So what are some ways you could approach this conversation? You could be straightforward about the risks and of undergoing the intervention and explain, just the likely medical course by not intervening. You could inform the patient, their family, and their team that you have met with the ethics department and they determined that it would not be ethical to proceed with the procedure. You could tell the patient that they will die on the table if you intervene. And then you could also offer the patient a referral to another provider. And then I have some combination answers there at the bottom. So we'll go ahead and let you guys put in your responses. Okay, so I guess it's clear that you guys will not see the responses, and I'm really sorry about that. Not very technologically inclined, but 38% of you said you would be straightforward about the risks of undergoing the intervention and explain the likely medical course. 13% of you said both A and B, so you'd be straightforward and also talk with the entire family and the team about your conversation with the ethics department. 25% of you said you would do A, B, and C, so you would also be really straightforward with the patient and tell them they would die on the table if you intervened. And then 25% of you said you would do a combination of all the above. So, I think it is really important to be honest with patients and their families about the expected course of a treatment. And I mean, it doesn't help anyone if you sugarcoat or lie about anything. So I think it definitely is important to be straightforward. With option B, again, being open and honest and ensuring that everyone has participated in the conversation and everybody understands the goals of care, the harm benefit ratio, and all that kind of stuff will be integral in ensuring that everyone can make an informed decision. And as to referring to another provider, this is also definitely an option, and maybe Michelle can speak more to this on my next slide. But I think, as a provider, if you don't feel comfortable performing a certain intervention and a patient and their family are pretty insistent about it, maybe referring them to another provider can help provide them with peace of mind about this, about the scenario. So again, some points to consider. Talk to the referring team first, explain your rationale about not wanting to perform the procedure, and make sure that both care teams are delivering a consistent message to the patient and to their family. Because again, if there's discord between the teams, then the patient and their family are not really going to know who to trust, and they won't know who to believe, and that'll just make moving forward that much more difficult. And again, just to emphasize, facilitating this conversation, which will definitely be difficult, will be a lot easier if there's already been an established practice of having regular family meetings from the start of the patient's course of treatment. Another thing to consider is the importance of utilizing your own support systems to help you get through these difficult situations, because these conversations will definitely be hard and it'll take a toll on you personally as a care provider. So it's important to make sure you take care of yourself as well in these difficult scenarios. It's also important that when you do seek out help from either the ethics team or the legal team or even another colleague, that you don't pass blame onto others. You can definitely get some support from the palliative care and ethics departments, but again, you have to make it clear that you have assessed the situation and you have determined the best course of action for the patient. And lastly, to go back to that point about making a referral to another provider, again, this might make the patient feel better if they see someone else and they get the same message. And when you make that referral, you can also consider informing the provider as to why you declined to perform the intervention, so they can also understand your justification when they take a look at the patient's history and have a conversation with them. Michelle, I didn't know if you had anything you wanted to add here.
No, I think you said it perfectly well. I agree that sometimes it might seem uncomfortable to refer the patient to another provider as if like you're not willing to do it, but maybe they will. But I think if we view it in a different light and instead view it as giving the patient an opportunity to chat with somebody else who might kind of repeat the message that you might have to help them really feel like this is the best course of action, it's not a bad thing to do. So it's important though who you refer to, I think, to explain, like you had said, the rationale, because you wouldn't want to refer them to somebody and have them do a procedure who kind of hasn't really thought about the futile risks of the procedure and goes ahead and proceeds with it. So it's really important to have that communication.
Yeah, I also think like framing's everything with this, right? Like you want to be an advocate for your patient. So, being straightforward with them, telling them those things. And then, unfortunately, if you still disagree and you feel like, I do need to get a second opinion or things like that, how you frame it is everything. So rather than, example would be like, is that second opinion, rather than being like, well, we can't disagree and I'm done with this. And now you're someone else's problem. It's more of that, hey, it sounds like, you have a lot of reasonable concerns. I want to bring in my colleague to weigh in, and so we can talk about this together. It means something very different. Same with like the ethics team, rather than like coming to someone and being like, hey, your concern is unethical. Being like, hey, I got my colleagues here which think about these problems all the time, and I wanted them to weigh in and explain kind of their thought process with it. So it seems maybe subtle, but I think it's everything in these interactions.
Yeah, thank you both. I think that's really important and definitely something, I think that's a skill that'll be learned with time, especially as, I start residency soon, hopefully, because those are definitely difficult conversations, and it is all about how you frame something and just making sure you're showing the patient that you're on their side and you're just trying to do what's best for them. So now that we've gone through our case discussion or our cases, just wanted to talk about some strategies that you can use to mitigate providing futile care. And we've already talked about a few of these, but just to kind of really bring it home, it's important to establish mutual respect between the patient, the patient's family, and the physician and the care team. Establishing this mutual respect early on will make these conversations easier and will create a trust between you and the patient, and hopefully that'll mean that you'll be able to participate in shared decision making, and they will heed your advice when you provide them with information. And again, improving communication between healthcare teams in order to provide a consistent message is essential. Making sure care teams are all on the same page will make sure that a consistent message is being delivered to a patient and their family. And, you know, I kind of think of, if one team is saying one thing and another team is saying another much more negative thing, the patient and their family are going to be less inclined to listen to the negative thing, even if that's, you know, the more straightforward and honest perspective. So it's really important to just establish what the goals are, establish that everyone's on the same page, and make sure that everyone is just talking to each other and being respectful of each other in that way. Another option is creating standardized guidelines for navigating these types of situations. I think having a rubric or an algorithm to help healthcare providers navigate these kinds of situations could be helpful in decreasing the frequency of providing futile care. In the literature right now, there are a few sort of rubrics for this already out there at different institutions, but there's definitely not a consistent or standardized guideline that has been established. So this is something that you could even work on at your own institution and work on establishing if you feel that there's kind of a deficit in that way. And lastly, again, using your resources that are available to you, seek out the ethics team and the legal teams at your institution, because they can really help facilitate these difficult conversations between patients and their care teams. So take-home points. Obviously, ethical considerations are really important to determining the futility of treatment. And the main strategies to avoid providing futile care is just lots of communication, and lots of communication early on, making sure everyone understands the goals of care and everyone understands, you know, the best ways to get there. And again, use your resources and provide interdisciplinary care. It's you're not in it alone when you're treating patients with in difficult situations, so it's important to make use of those resources. So these were the sources I used for this, and I guess I wanted to give an opportunity for questions, but I don't know if participants can speak in this. But I guess before we do that, I just want to say thank you to SIR and SIO for supporting our Applied Ethics and IR initiative, because this would not be possible without them. And then this is my contact information if anybody wants it. And if there is a way for people to ask questions, I'm more than happy.
People can ask questions in the chat if they have any.
Okay.
While we're waiting for any of them to trickle in, I just wanted to say what a great job that you did, and I think you've done some great work here and have really laid out futility for the IR community. So just want to applaud you for that.
Thanks so much.
Likewise, this was excellent. And actually, like in our survey of IRs, this is like the #1 thing as far as ethical topics on people's mind in our specialty. So it's really awesome that you put this together.
Thanks, Eric. Well, I don't see anything popping up in the chat box, but thanks for everyone for attending. I hope everyone enjoyed it.
Great work. Thank you.
Thank you.